Interns, we've got you covered. Go to OnlineMedEd.org to see all of our intern resources.
This is Shock 1, and it's how I approach someone with hypotension. I will usher a word of caution at the beginning because I'm going to teach you real medicine, but I'm going to use words that are different than pulmonary critical care attendings. I will show you how to link what I teach you back to the classic models of shock. But this is more about actively approaching a patient and knowing what to do next. Knowing what to do next is what we talk about in Shock 2. We use this model to speed through it and to get to the interventions. So let's start off with the equations 4, 5, and 6 from the 10 equations. This is my approach, the advanced organizer, to shock. The mean arterial pressure is a product of the cardiac output times the systemic vascular resistance. What that means is cardiac output and systemic vascular resistance, as we'll see, the systolic whomp and the tone the blood vessels have contribute to the blood pressure. In the ICU, you'll be using MAPs, not systolic blood pressures. This tells you that if one goes down, the other will go up. Cardiac output is a product of the heart rate and the stroke volume. The stroke volume is a product of preload and contractility, such that if any one of these is compromised, the others should respond. The major distinction we make, though, is between cardiac output and systemic vascular resistance. In the classic naming of shock, problems with systemic vascular resistance are named distributive. I would be doing you a disservice if I at least didn't write them on the board. Very small and in the corner. The classic models of shock, classic names, are distributive. And I start here because I can put the dashed line right where my dashed line is. The others are cardiogenic, hypovolemic, and obstructive. And you'll see how I'll color code them as we go through my method. But let's start off with distributive shock. Tone. What happens when systemic vascular resistance breaks? This is a blood vessel. It has a muscular layer around it and a lumen. How tight that vessel is clamped down is determined by tone. Tone is systemic vascular resistance. Tone determines the diastolic blood pressure. Arteries have that muscular layer so they can adjust, they can constrict and dilate. They also have that so when the ventricle beats, they can accept all that pressure and then snap back to where they're supposed to be. How tight an artery is determines the diastolic blood pressure, is determined by the systemic vascular resistance. If tone increases, there's a vasoconstriction. The lumen gets smaller. It's harder to get through there. All that muscle has ranked down. This would be an example of increased tone. And so the diastolic blood pressure would go up. If there's vasodilation, the path of resistance through there is less. There is less tone. And so the diastolic blood pressure would be less. Causes of shock that are caused by the lack of systemic vascular resistance result in vasodilation. The tone is low, so blood will flow. On the other side of this is the systolic whomp, caused by the cardiac output. We have that original blood vessel, and the goal here is for me to draw similar, if not identical, arteries to show that they have the same tone, the same diastolic blood pressure. On top of diastole, we have systole. This is how much that artery distends, the pressure it feels. This is the change in systole is the whomp. Now, whomp doesn't sound very technical, but trust me, this will work. Work with me. If there is less systolic whomp because cardiac output is compromised, the change in systole will be decreased. The systolic change created by the beat of the heart. If instead cardiac output were increased, there would be more change in systole. The change in systole would increase. What is the change in thing that I'm talking about here? Quintessential blood pressure is 120/80. The change in systole is 40. The baseline tone is 80. If you vasodilate, diastole gets lower. If you vasoconstrict, it gets higher. If you increase cardiac output, the difference between the two gets bigger. If you decrease cardiac output, the difference between them gets smaller. How does that relate to our discussion? Well, if you have a problem, a systemic vascular resistance, you have a problem with tone, you decrease the systemic vascular resistance, and by the equation, cardiac output will increase, specifically heart rate and contractility. Contractility contributes to the systolic whomp. If we follow this strictly, the blood pressure will fall because the diastolic pressure gets low. But in order to compensate, the systolic whomp will get higher. This will create a wide pulse pressure. It will not be weird to see 70/20. Or more importantly, before they actually go into shock, you can see a wide difference between the systolic and the diastolic blood pressure. Because it's vasodilation, they're not shunting blood to the core, all the arteries are open. So even though their blood pressure is low, you have to do this, of course, before you start pressors. If you go up and touch someone, not their fingers, go to find a thin female in a cold room, her fingers will be like icicles, but not the wrists, not the forearms, not the shins. Use the back of your hand, most temperature sensitive, not with a glove on, and touch their wrists and ankles. If they are warm and in shock, you've diagnosed it as distributive. You can confirm that with a wide pulse pressure. Conversely, if the problem is not systemic vascular resistance, regardless of what it is in cardiac output, because cardiac output falls, systemic vascular resistance will increase. It means that regardless of the cause on this side of the dotted line, tone will go up. And so the exact opposite will happen. If systemic vascular resistance is not the problem, those vessels will clamp down, shunting blood away from the periphery to the core. So you can expect then problems of not systemic vascular resistance, that is problems of cardiac output, will have a narrow pulse pressure. It will not be strange to see in cardiogenic shock 70/60 as opposed to 70/20. He'll be cold and in shock. Their wrists and ankles do not get any perfusion. So that's the first thing I recommend people do, is as soon as you walk up to somebody and say, hey, this person's in trouble, touch their wrists and ankles, look at what the blood pressure, pulse pressure is. And all of a sudden you have which side of this you're on. The reason for this, and you'll learn more in the next lesson, is because this gets vasoconstrictors. All of these don't. And if you pick a vasoconstrictor for these, all you're doing is contributing to the pathogenesis of their poor organ perfusion. All right, so before we get into the list of diagnoses, how do you recognize shock in the first place? So the one that people don't have trouble with is frank shock. And it has nothing to do with some dude's name. This means that it's obvious. Frank shock, and again, we're going to start using MAP in the ICU, is a MAP less than 65. It is no longer a systolic blood pressure, less than 90. MAP, less than 65. MAP goal in resuscitation of someone in shock is 65. Now that one's not going to miss. Machines are bing, bing, bing. It's 70/20. Nurses are freaking out. Everyone's trying to get you. You can't do anything else but pay attention to that patient. That's obvious. People don't miss that. If you see a low number, get up from the computer and go to the patient. What people miss are occult shock and the shock index. Occult shock happens because some people have reconfigured autoregulation. If someone's hypertensive for a long time, they're used to being 200/140, their blood vessels are going to adjust to a higher level. Now that example is extreme, and that's probably not what you're going to see. I usually coach occult shock like this, so you can visualize it. It's extreme again, but it helps to hear it and see it. You look at the clinic note, and they're 180/110 on 5 blood pressure medicines. Right now in front of you, they're 120/80, but won't wake up on 0 medicines. That person's in shock. The person's in shock because their body is used to a different MAP. The way you actually use this in practice is that the MAP goal may change based on someone's condition. Cirrhotics, especially the advanced decompensated ones, run low. Their blood pressure is always low, so a MAP of 55 may be appropriate for them. All comers, 65. Someone who is a very aged hypertensive coronary artery disease patient may need a MAP goal of 75. Occult shock occurs because it's a relative hypotension. But how does that help you? It helps you because you look at the lactic acid. Lactic acid has nothing to do with sepsis or septic shock. You will use the lactic acid once you've diagnosed sepsis to find out how bad it is. Lactic acid is a sign of poor tissue perfusion. All forms of shock elevate the lactate. This is to illustrate, you walk in the room, you look at the monitor, the number's not that bad, but the lactate's 12. Tissue is still dying. It may not be global, but if the lactate is elevated, you have to pay attention. It could just be that one area of bowel is dying because it has poor arterial flow, and the lactate could be elevated for that. But also consider the substrate. If the number is 66 on the MAP, that's still catastrophically low. And so if the MAP is above 65, but the lactic acid remains high, that is occult shock, relative hypotension for that person. Last is the shock index. The shock index is calculated by taking the heart rate and dividing it by the systolic blood pressure. If this is greater than 1, it's positive. And being positive is bad. The data goes like this. If there is a shock index, it is more likely the person will express an elevated lactic acid. Elevated lactic acid has a higher mortality. The shock index, you don't need a lab for. It's like the SIRS criteria. It is not diagnostic, but it helps as a screening tool. It gets more useful the worse the substrate. A 23-year-old woman with pyelonephritis with a fever of 105, whose blood pressure is always 100/40, who currently has a heart rate of 160 because of the fever, and her blood pressure is 100/40 still, like always, has a positive shock index. And she's walking back and forth to the bathroom because of all the fluid you gave her. She probably doesn't have shock. But as you take care of the elderly population, the more common people you're going to see for evaluation of the ICU and shock, you realize that their maximum heart rate can't get that high. And most of them have a high blood pressure to begin with. So when they do convert, that number flips and the heart rate gets higher than systolic blood pressure, that is a sign that something's more sinister is at stake and you should pay more attention. Just like the SIRS criteria, look for sepsis, doesn't define it, but it perks up your ears to say, hey, I need to pay more attention. All right, different types of shock on different sides of the line. Here is the classic model explaining diastole and tone, systemic vascular resistance, and the systolic whomp. Let's use this as the advanced organizer to keep track of the types of shock. And this is what I do. Whenever I see hypotension, I start here and work my way around the board. Heart rate, you only have two options. It's either too fast or too slow. Red, because it's cardiogenic. Contractility comes down to myocardial infarction and CHF. Red, because it's cardiogenic. Cardiogenic doesn't tell you what to do. Shock arrhythmias, inotropes for heart failure, not vice versa. I jumped because they're both red. All right, moving around the line, coming to preload. There's two types of preload. There's those that are volume down, and that is the 4 Ds: dehydration, diarrhea, diuresis, and hemorrhage. The other type of preload shock is obstructive, something that gets in the way of the ventricles filling. There's the RV problems, tension pneumothorax, and pericardial tamponade. And there are LV problems, PE. Black because obstructive shock, volume down because it's hypovolemic. And finally, come to systemic vascular resistance. Sepsis gets its own line, and it's on top because it's the one we deal with the most, and it's treated differently than the others, as you'll see in the next video. There's also anaphylaxis, spinal trauma, anesthesia, and Addison's disease. I'm going to go back around clockwise and show you what you should use in order to say, hey, this is the problem. Labs, history, whatever. You already have the wide pulse pressure, Warman shock. Generally, this is going to be from the history. Labs don't help. Contractility, if you have issues with the heart, you get the heart labs. BNP, troponin, and echo later. That's usually harder to get. For the issues with preload, and this is why I do it this way, both volume deplete and obstructive causes will initially respond to intravenous fluids. So start there. And for arrhythmias, easy, get the EKG. So we're going to use this model of shock using this diagnostic advanced organizer in order to move forward the next 2 lessons on shock. The next one being on the interventions, on how to fix someone in shock based on the diagnosis using this organizer, and the third, specifically what you're going to see the most, septic shock. This is shock 1, approach to shock.
Ooh, being an intern is tough, huh? Well, with OnlineMedEd's videos, Case X, and Intern Bootcamp, it can't be easier.